Hey everybody, welcome back. It's Stahlman, and it's Friday, which means the Doctor's In Live with TOA is on and going. I'm sorry I wasn't here the last couple of weeks. My wife and I were down in South Carolina enjoying the low country, so I'm not that sorry. But it was great, and I hope everybody's doing okay. I hope everybody's healthy. See this bright shining face? This is Dr Bowman. He's our guest for today, and I'm going to let Dr. Bowman tell us about himself and what he does, but the title of this episode was Pain Management. I think we're going to kind of narrow the field just a little bit because that's a pretty broad topic, but a lot of our patients have some need for pain management, whether that's acute pain from an injury or a surgery or a chronic pain problem, and there's all kinds of pain and all kinds of ways of managing it. And so maybe today we'll get some information about what's out there for some general things as well as some specific things. As always, remember, while Dr. Bowman and I are both physicians here with TOA, we're not your physicians, so please remember that the information that we're going to talk about is for educational and informational and entertainment purposes only. This is not medical advice. If you have problems, if you have a concern that we bring up that might apply to you, please either get a hold of your primary doctor or contact TOA, www.toa.com. We're all over the middle state. We have 63 doctors, I think, now, and we've covered essentially all musculoskeletal specialties, and we can find somebody to help you with your problems. So with that, let's move forward with welcoming our guest today, Dr. Bowman. Tell me a little bit about yourself first, your background, and then let's get into the meat of the topic.
Well, first, thanks for having me. I'm happy to be here. I grew up in southwestern Pennsylvania. I did some medical school there and then went to Texas for a few years for some training. Then I ended up at Vanderbilt to do my fellowship. And while there, I was fortunate enough to come on here at TOA to do some interventional pain management for you all.
Awesome. Yeah. So he is a local boy simply because he trained here, but I didn't realize this, but he's brand new. I thought he was in practice for a little while, and that's my bad. So he's one of our youngest physicians, which is encouraging to me because we're going to keep him around a while, and we've got a long history. So you mentioned interventional pain management. Tell me what that is, especially in the context of the general term pain management.
Sure. So, interventional pain management, as the name implies, is using interventions. A lot of them are minimally invasive, using needles or very small things that aren't very painful when they're performed, and they don't require a surgery to alleviate painful conditions. They can be from headaches to neck, back pain, pain in the extremities. And the reason that it's kind of become popular in the recent past is because it allows patients to have relief of their symptoms, be more functional, and enjoy their quality of life without being reliant on medicines that can have side effects, that can be habit forming. And in the recent past, that has become an issue, especially in this part of the country, where people just kind of get prescribed medicines and they don't get taken care of maybe appropriately in certain ways. And I think that's why I enjoy so much what I do, because people are able to get the relief that they need and not rely on the medicines that maybe make their brain feel foggy or make them sleepy or drowsy, and they can really enjoy life.
So how does somebody a patient decide or understand when interventional pain management might be helpful? I refer my patients to an interventional pain management specialist most of the time for their pain needs. Occasionally I'll use a traditional pain management group, which is basically medications, if there's no intervention that will really help these people. But if somebody comes into the office and we talk to them about interventional pain management, kind of what does that mean to a patient? What am I kind of setting them up for? Or what might they be looking for if they call the office and say, I need interventional pain management? What kind of things are they trying to manage?
I think that when a patient seeks out interventional pain management, they can expect to get a full workup. And the beauty of being here at TOA is myself, Dr. Todd, Dr. Clendon, Dr. Ashley, the other gentlemen that do the same thing that I do, we work closely with you guys, the surgeons, spine surgeons, the other orthopedic surgeons, to get the appropriate imaging to see what needs to be done. However, if you come to the interventional pain management doctor, there's a very low likelihood of getting a surgery from them. So there's a lot of steps that can be taken prior to or after surgery. If someone falls and has pain, we can evaluate them and potentially do something to alleviate their symptoms until they heal up. Or if they do need surgery, then they're in the right place, we can refer them over. But I think the biggest thing that we do that's different than a lot of the surgeons is that we're obviously likely not going to be performing a surgery, and more likely to be performing a minimally invasive procedure. The patients walk into the procedure suite or to the surgery center that day, and they go home the same day, and they really don't have typically very many restrictions thereafter. Most people return to work the next day.
What's probably the most common thing you manage? What do you see most common?
Most often is neck and back pain. A lot of people that have a bulging disc where they have pain either going down, starting in their back, going down their leg, or in their neck going down to their arm. A lot of people get concerned. It is very concerning when that happens because it's exceedingly painful. More often than not, those do resolve with time, but epidural steroid injection is a steroid injection that goes around the nerves that are being pinched to alleviate the symptoms until the body heals itself. That is probably the most common thing that we do, but there's other procedures that we do that help just with low back pain, neck pain that doesn't radiate, or even pain in the knees, arms, really anywhere.
Really? So you can do things like injections for those other types of problems too?
Yes.
How big of a role are medications in your practice? Because I know that there's all kinds of medications, pain medications, anti-inflammatory medications, etc. What types of medications might you use to try to help pain problems?
There are medications, for these pains that I just spoke about that are more nerve pain where the nerve gets pinched. There are medications that do help with nerve pain. My goal is to use them transiently until we can do the intervention so the patient has some symptomatic relief until we can get the intervention done. And then typically after that, they participate in physical therapy, which is another thing that we rely on a lot. And I think that using medications for a short time in order to allow the patient to kind of get to where they need to be and then slowly come off of them that's typically how I use medications versus having someone be on it for forever or for a really long period of time, just because they do carry side effects that a lot of people don't like.
Yeah, and I'm totally in agreement. That's my practice philosophy, and functional restoration, getting you back to your lifestyle without impairing you from medication side effects or addiction and that type of thing is really very important. Let me ask you this. How do you help somebody, for example, who you might consider doing an epidural injection on, but they're scared of needles? What do you do to try to help them? Because I think they can be helped by how can you help them get over that?
Yeah, that is a common thing that comes up, and I would say by and large, it's way more common for someone to say after the procedure's wait, you're just done, you're already done. They think that I'm just getting started and it's done, and really it is a matter of just a little bee sting and then the numbing medicine goes in. If people have had bad experience with needles in the past, which some people have, there's some oral medications that can help relax before the procedure, things like that I sometimes do. But really, I think the biggest thing is for patients to be alert so I can talk to them so they know what to expect. And I talk with them the entire time, sometimes about what I'm doing, sometimes about the world we live in, which is sometimes better than others. But and really, I don't run into that problem very often where people have an unpleasant experience.
Yeah, that's actually been my experience, is that people will come back and say, gosh, it was a lot less traumatic than I thought it was going to be.
Right.
I would do that again, and they were so afraid. And even if somebody's had a bad experience with a previous injection, many times that can be alleviated or assuaged by talking to them, by just openly, leading them through the process and just kind of allaying their fear a little bit. So how often, this is another just random stuff, so if somebody has an epidural injection, how many of those can somebody have, or how many should they have for a specific problem? Is it something that you can use indefinitely? Is it something that, you know, has a limit to what you can use them for as far as time frame and whatnot?
Yeah, so I try to limit to epidural steroid injections to 3 or 4 in a year. Now, if someone has an acute, where their disc is bulging and it's really hurting bad, sometimes we'll do a few in a row right off the bat just to try to get them some symptomatic relief because they're having trouble walking, they're having trouble going to work, taking care of their family, what have you. You know, my thought is if we do those up front and then down the road we do have to do that many in a year, it's time to have a discussion whether or not it is the right thing, or if they need to speak with someone like yourself or Dr. Snowden or Dr. Shibiyama or Atanda, one of the other spine surgeons, Dr. Mackey, to discuss if maybe there is time for surgery.
Mm-hmm.
But you know, there's a lot of people that come back every 6 months, every year, just because it starts to flare up again. And you know, some patients that are especially very elderly don't want to think about having a back surgery, and if that's the case, I do think it's the right thing to do.
What about diabetes? So you've got folks that many of your injections, the epidural steroid injections, are steroids. Obviously, steroids can increase blood sugar problems and kind of make your diabetes kind of go wacky for a while. Is that an absolute contraindication? Is it a relative contraindication? Are there ways to do your types of procedures and still keep them relatively stable with their diabetes?
Sure. So I always check the blood sugar before I do the injection to ensure that their blood sugar is somewhat well controlled. And I typically ask if, you know, what their blood sugar typically runs, and then see what it's running that day to kind of get an idea of if they're controlled or not. If their blood sugar is high, and when I say high, I'm talking in the 200s, sometimes I will have a conversation with them about potentially rescheduling on a different day that they have their blood sugar lower, because steroids do inherently bring the blood sugar up. And then the other thing I often do is use a little bit lower dose of steroid in diabetics. It does still provide symptomatic relief for them, doing the right thing. So there is no absolute contraindication, meaning that we absolutely don't want to do it. Of course, we want to help patients by doing injections, but you know, there is a risk of having it go up. And I think it just comes down to having a conversation with the patients, making sure it's controlled. And sometimes, if they do have other issues, such as around blood thinners, which is another good thing to bring up, you know, we want to make sure they come off of their blood thinners. So we do that by talking to the doctor. Typically it's a cardiologist who prescribes it, to make sure that it's safe for them to come off for the appropriate number of days and then go back on them afterwards. Similar thing with the blood sugar and the diabetes. We want to make sure that they're managed appropriately, have the ability to check it, so if it does go up too high, they have a way to intervene on it, whether it's you know, increase their insulin dosage or take medicine, something like that.
You mentioned the blood thinners. What's the risk with the blood thinners?
The risk of doing, you know, some of the epidural steroid injections or any other injection is the risk of bleeding. People typically think bleeding means coming out of the skin where the injection went, but the bigger risk is having bleeding inside the spinal canal area where the epidural injection is performed, which can be very bad. So it's definitely a very important thing for patients to be off of blood thinners, and if they're not and they show up, that is an absolute contraindication, meaning that we will not do it, because the risk of harming them doesn't outweigh the benefit.
Yeah, that really makes a lot of sense, and so that's an important thing when people are getting set up for something like an epidural steroid injection, to be honest and open with your use of blood thinners, the big ones, you know, Coumadin, warfarin, Eliquis, Pradaxa, Plavix, etc., but also things like the anti-inflammatory medicines, which have a relative blood thinning effect, not quite to the same degree, because not being truthful with that can put you at risk. And when he says it can be really bad, he means really bad, like you could be paralyzed. If you bled inside your spinal canal and the blood collected there and squeezed your nerves or your spinal cord, you could cause permanent nerve damage in fairly short order before I, for example, could get a hold of you and take the pressure off. So it's really important for people for those types of things, to really be truthful about them and also follow the directions before the procedure of how long you need to come off of it and whatnot. Be truthful about it, because we're doing it for your safety. It's not something that we're trying to punish anybody for. We're doing it because it's a safety thing. Fortunately, I think the majority of people can come back on their anticoagulants pretty quickly and just step back into their normal routine. Is that right?
That is right. And if there's someone that is really high risk, there's different medications that can be used to bridge the gap, for lack of a better term. So when they come off of their blood thinner, there's a shorter acting one that they could use, such as a Lovenox shot that a lot of people have had after surgeries, hip surgeries, things like that. They can give themselves so that they're really only off with the blood thinner for about a day for the procedure and then go back on. So there are options. So if you are on a blood thinner and you have a lot of heart problems or cardiovascular issues that put you at risk, there are options, but it's just a conversation that I like to have with the cardiologist to ensure safety. That's all.
You'd mentioned that people with neck and arm pain and lower back and leg pain can be candidates for these types of injections. Are there differences or more concerns or less concerns about injecting the neck versus the lower back?
Yeah, so sometimes in the lower back we do the injections around, it's called in the epidural space, which is a space that sort of lines the sac that holds the spinal cord. Most of the injections in the low back are below where the spinal cord ends, so there's not as much risk of nerve damage, whereas in the neck, the spinal cord is right behind the epidural space. So these injections are all performed with x-ray guidance. So we take pictures with x-rays to see where to enter, and then more importantly, we take a picture shooting kind of across the patient. If they were facing this way, the x-ray would show there to see how deep we're going, and that really minimizes the risk of damaging the spinal cord and things like that. And very well.
I don't know if you were around. You knew about it because you were in training, but you weren't around in town when there were a number of years ago, there was a big infection problem with contaminated steroid medications being given and people getting meningitis with a fungus, which is a really bad organism. That's not something, while we always worry about infection, that's really not something that people need to worry about at this point.
No, I do still hear some patients that have been around for that issue that have that question, and things are so refined anymore. I don't really think twice about that. It's not a concern of mine.
Yeah, that was really a product problem.
We had a question come in on Facebook that I was going to read out to you. This is from Russ, and he's asking, what are your thoughts about SI joint fusions? I've heard that these procedures are doing well to relieve pain for folks when the SI injections aren't working as well.
So that's a great, actually, topic because it speaks to both of our practices. So the sacroiliac joint, or this SI joint, in Kevin here is the joint where your spine attaches to your pelvis. And so it's usually seen from the back. Yeah, and it's kind of a weird joint. It's built the same way as a hip and a knee. It's got cartilage in it, it's got joint fluid in it, it's got joint tissue in it, but it doesn't move much. I kind of tell people it kind of looks like my knuckles put together and it kind of wiggles a little bit. But because it's a big joint that transmits the forces of gravity from the ground up through your leg and your body weight, every time you take a step, you bear weight through the sacroiliac joint. So if that joint is inflamed or wears out, it can be painful. So in your practice, before we talk about surgery on that, what kinds of things can you do for sacroiliac joint discomfort?
So typically when patients come in with sacroiliac joint discomfort, I set them up for an injection, which is again performed using x-ray guidance to ensure that the needle goes right into the joint. It's very well tolerated. I also typically prescribe an anti-inflammatory, assuming that there's no contraindication, and then set people up with some physical therapy and see them back to see how they're doing. Most people do pretty well with injections. If there is an issue where the injection works temporarily or it only provides relief for a week or 2 weeks, that clearly isn't something that's sustainable. A little bit more advanced technique that we do is using it's called a radiofrequency ablation, where it uses electrical current. So it's a series of needles that we place kind of along the inside aspect of the sacroiliac joint, and the nerves that the reason the SI joint often hurts is because there's some irritation or inflammation or arthritis in that joint, and those pain signals are transmitted from the nerves that essentially come in and go up the spinal cord, so they'll perceive this pain. So there's a procedure where you can put a series of needles. It's about 3 or 4 needles that go up and down, and they're attached to a machine. The patients obviously had a lot of numbing medicine, so there's not a lot of discomfort, and that results in essentially burning these nerves. It sounds kind of barbaric, but it's very well tolerated, and that minimizes the transmission of pain signals from that joint. Now, with that being said, the arthritis or the pain generators in that joint do persist, and arthritis typically gets worse with age. So that is the one thing to talk with patients about if they want to avoid having a surgery, or maybe aren't a good surgical candidate for whatever reason it may be. They may have heart problems, lung problems, uncontrolled diabetes. This is a good option. But the next step beyond that would be a fusion, and that's where you come in.
Yeah, so the sacroiliac joint has long been known to cause pain because it's a joint and it has the same kind of innervation that other joints have. But it's been a real challenge to treat surgically because it's kind of a deep joint, it's hard to get to, and most of the traditional surgeries that we had were really invasive, big operations, very painful, long recovery. And so there was a time, probably 50s to 80 years ago, where people would do fusions of the sacroiliac joints, and that lost favor because it was such a horrendous experience for patients. Well, about 15 years ago, 10 years ago, some folks developed some minimally invasive techniques where we can stop the motion or reduce the motion through that bad joint by using an implant system, and there's a variety of them, but the gold standard, the one that everyone measures their results against, is what's called the iFuse system. Is basically 3 implants that are driven through a small incision in the skin, through the buttock muscles, which are here, across the joint, and they're kind of pegs across the joint. What happens is it essentially spot welds the joint, so it can't shift, move, flex, or bend. And then the hope is that the joint will become more and more and more rigid and pain will decrease. So that's actually it can be a very good procedure for the right patient. The challenge is really finding the right patient because, as I think you'll agree, there's a lot. I always tell patients, if I took a 6-inch circle right here and centered it over the area where your pain is most, there's a lot of parts that can cause pain. The joints in the spine, the discs in the spine, the sacroiliac joints, the ligaments, the attachments of the muscles to the bone, etc. And it's sometimes hard to narrow down the focus, but if we can narrow down the focus and say, it seems that the sacroiliac joint is the primary cause of your pain, sacroiliac joint fusion by these minimally invasive techniques can be very, very helpful. And we work together on that. So Dr. Bowman will work on the therapy and the injections and try to manage it that way. If it's not being managed well enough, one thing I do is I send them back to somebody like Dr. Bowman for a diagnostic set of injections where we inject the joint with Novocaine, some sort of local anesthetic, and I don't even know if they make Novocaine anymore. And it numbs up the joint, and if that takes away the patient's pain for the lifetime of that local anesthetic, that's a helpful diagnostic tool to say, yep, that seems to be the primary source of the pain. And if we've ruled out other causes, then those patients have a very high, somewhere between 70 and 100% chance of relief of their pain with a relatively minor procedure. So that's something that's come about over the last few years. More and more insurance companies are accepting of that type of procedure, and so it's a nice tool to have in our toolbox in treating this kind of problem. The challenge, obviously, is chronic back pain is terrible for a lot of people. We don't have a lot of good cures for chronic back pain because most of the time it's related to the degenerative wear and tear, breakdown changes that life brings us, and we don't have spine replacements like we have hip and knee replacements, and so there's a lot of compromise involved. That's why there's a lot of caregivers for back pain problems: interventional pain management doctors, chiropractors, spine surgeons, pain management doctors, acupuncture, massage, etc., because there's not one easy fix for everything. So that's a great question. So branching out, what other kinds of strategies do you have to try to help with pain management? So we've talked about injections, we've talked about therapy and medications. Are there other things that you do for whatever pain problem it is that you might be able to help people with? We were talking before coming live about spinal cord stimulation. Do you have experience with that? What kind of experience do you have with that? What kinds of things potentially can you treat with those electronic technology devices that you all have in your toolbox?
Sure. So spinal cord stimulation is it's a procedure, and it's more of a surgery. It does involve implanting a battery, but essentially it's like a pacemaker that we're familiar with people that have heart conditions. That sort of goes in the epidural space, so the leads, they go in between the backbones and go up kind of the back part of your spine in that epidural space that we just talked about, and it gives off little electrical signals, and between the two wires, they sort of talk to each other and essentially stop the pain signals from transmitting, so you don't really feel them anymore. And the types of condition that really is advantageous for is people that have kind of low back pain that radiates into both legs, one or both legs. Oftentimes people have surgery to fix that type of pain. However, if they don't have a pathology that is operable, meaning that there's nothing that is really pinching a lot on their spinal cord, we get an MRI and you need something to be wrong in order to fix it. Some people have that type of pain and there is nothing wrong with their spine, so those are good candidates. Sometimes people have had surgery and they feel better, but over the course of time their pain seems to come back, and it's pretty rare that happens, but when it does, if there's no pinching of the nerves and they still have that pain going down, they're good candidates for that type of procedure.
Have you had pretty good results with those types of procedures?
Yes, I have, and like you said, it's really comes down to patient selection. The type of pain that's meant to treat is pain coming from the nerves. So if people have pain in the muscles, maybe people have a job or a sedentary lifestyle where they have a lot of pain in their muscles, it's not as helpful for that as it is for really that kind of nerve pain. When I say nerve pain, it's more of like a shocking, burning, tingling, numbness, kind of pain like that goes down their legs. That those patients are better candidates in my opinion, and I think it is important to pick the right patient, because it is a big commitment having something implanted in your body. It's not a small decision to make.
Right. And I implant, that's the official medical word. I install spinal cord stimulators in a variety of ways too for people, and it can be a very useful tool, again, in the right patient. It doesn't work, there's not one hammer for every nail. That's the problem in our world, and we have to be able to compromise a little bit, because we're never going to make you as good as you were when you were put on this earth. But what we try to do with all of our technologies, our medicines, our therapies and whatnot, is give you as functional a lifestyle as we can with the least amount of intrusion as we can. I think that's your philosophy as well. We're kind of getting close to wrapping up. So I'm going to kind of let you just freeform it. Tell us what you're interested in, other things that people might want to think about, what types of things really float your boat in the patient care world, and any final thoughts.
Sure. So I get a lot of questions from patients that they're getting older, they're having the degeneration you talked about, and their pain seems to be becoming more of an issue as they go, and they often ask, what should I do? Should I get a massage? Should I go to a chiropractor? Should I exercise? Should I not exercise? Should I go swimming? And I often tell patients, if you don't like broccoli, you're not going to go to the salad bar and leave your plate with broccoli. So I think that I try to tell patients to do things that make them feel good. If you go to a chiropractor, every chiropractor was trained differently, just like you were trained from a spine surgeon a little bit differently. Your style will change with time, but at the end of the day, you're sort of a product of the way you were trained. And if there's a massage therapist that really makes you feel good, I think it's worth doing it. If there's a massage therapist that makes you feel like you were in a fight yesterday, I don't necessarily think that's the right thing. So I think that people need to just step back and listen to your body, do things that make you feel good. Sometimes getting massage is the right thing to do. Swimming oftentimes makes people feel better because it is movement, it's not high impact because you're not holding your weight. So that's one thing I really try to talk with patients about. And I think that taking that philosophy, not only for people living with chronic pain, but just everyday life, I think that gets you pretty far by doing things that make you happy and make you feel good. And that's kind of the take home that I try to have every patient leaving, hoping that they can go do something for themselves and make them feel better, because I'm pretty passionate about that.
That's awesome. That's it's like I've cloned me here and put them in, because that's exactly how I think. Movement is good. Our bodies get bad with time. We can help fight off Father Time, but we can't win. but people can have very satisfying, fulfilling lives, maybe just a little different. And unfortunately, we don't have a pill or a surgery or a therapy that will fix everything guaranteed 100%. And I think active lifestyle is really the mantra for all of us in musculoskeletal care. Anyway, thanks so much. This has been really educational, really helpful. I hope it's been helpful to you guys. We're going to say hi to Carlos Johnson. Carlos, are you here, buddy? I hope so. We were talking about you earlier. Anyway, so we're trying to decide on a topic for next week. We're not sure we're going to have a guest. We may not. I may have to freeform it. I promise you, if I do it myself, I'm not going to be on my side like I was a couple of weeks ago. But in any event, again, thanks for tuning in. I hope this is helpful. Please comment on the Facebook page below. Go to TOA.com. You can learn about our physicians, backgrounds of our physicians, what we do, where we are. Oh, by the way, where do you see patients?
I see patients in both Stonecrest and Smyrna, and then also in Murfreesboro at the TOA location.
Okay, so if you're in Rutherford County area, Dr. Bowman is your guy. And again, you can learn more on our website. Go to the physician provider page and look up Dr. Bowman and others, and we can tell you what we do, where we do it, how we do it. We have physical therapy open. We have MRIs open. Most of our offices are currently open, although some of the really small offices right now are still not fully open because of the COVID-19 issues. Fortunately, we've been able to bring back many of our staff that we had to furlough. We're still working on that. So remember, despite what your beliefs are with regard to who caused what and what the actual outcomes are going to be, we're still dealing with an infectious disease that we don't know everything about. And so be smart, be cautious. Safety, common sense is probably a good idea at this point until we really understand what we're up against long term with this COVID-19 thing. Anyway, so until next week, we'll have some sort of topic for you. We'll figure that out over the next couple of days. Go out there, have a great weekend. Don't hold up a golf club in a lightning storm. That's never good. And anyway, go out there and live your best life. We'll see you later.